And we are back with another episode of Controversy and Comments. The Dr. Ab's reaction video took a turn I did not expect, so we'll talk about it. We're also going to cover some really interesting ideas about optimal nutritional strategies, and stick around for an in-depth conversation on imaging. If you guys are new here, I am Dr. Lily Johnston. I am a board-certified vascular surgeon. I also specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. Brit Popification says, unconscionable that you would give any credence to a discredited dentist who claims to be a doctor. I really tried with you in this channel, but unfortunately I can't rely on you to do some homework. Very scary. Bye. So this came up quite a bit in the comments for this video. And here's what I'll say. I don't actually do a huge amount of research on the videos that I react to ahead of time. I do it pretty intentionally. I watch them with you guys and just react to what I see as it comes up. And once concerns were brought to my attention about who this Dr. Abs is, I looked into it and I agree. I'm pretty disappointed in the fact that, in fact, he's a dentist, not a doctor. He does have some additional training, and his license has been suspended for recommending topical testosterone as a skincare product and not responding appropriately to claims about possible safety issues. There have also been some legal concerns around him, and I will not be reacting to his content again. I will not be endorsing his channel. I'm also not going to pull the video. And the reason for that is I still think the discussion around lab values on a carnivore diet stands on its own merits. And, you know, this is not dissimilar from content that has been presented by other people who have patients on a carnivore diet. It's a collection of 50 patients. It's not a study. It is a series, if anything. And yes, it's biased. No, there are no statistical outcomes here. But I do think that the conversation around what can happen with this way of eating is still relevant, and many of you find it valuable and useful. So let me just stay for the record. I don't endorse what Dr. Abs has done professionally. I am not necessarily supporting his channel or him personally, and I apologize if there has been a loss of faith in me in these videos because of that oversight. I'm still going to leave that video up because I think it's an interesting conversation, but I appreciate the feedback, and we'll do a little bit more due diligence in the future before reacting to other medical creators. All right, Micah says all these improvements can be explained with weight loss. And this is going to be a theme we come back to about what the optimal nutritional strategy is for individuals, because I don't think there's a one size fits all. In this cohort, we don't know what happened with weight loss or fat loss because that was not reported to us. I agree that many of these things do happen with loss of fat. We also know that fat loss, especially in a sustainable long-term way, is very, very challenging. The eat less, move more strategy has failed millions of people. If it were that simple, we would have solved obesity a long time ago. And the fact that we haven't means I think there's a more complex interplay of physiology, hormones, food environment, lifestyle, and all of these things come together. And again, I'm not sure that it's one pathophysiology. I'm not sure that it's one disease that is the same across all individuals. I think there are a number of different things at play, some hormonal, some psychological, some, again, relating to food environment and lifestyle. And there's a reason that it's now its own medical specialty. But people who come to me for fat loss and weight loss have tried eat less, move more, and it works, but briefly. It does not seem to work for a lot of people in a very long-term sustainable way. And so we have to look to other solutions. And for some people, a way of eating that does a lot of things. It changes hormonal signaling. It can create ketones depending on how the diet is formulated. It can remove emotional eating temptations and addiction temptations like any sugar or grain-based products, even dairy-based products for people who do dairy-free carnivore. All of these things make a carnivore way of eating, for some people, a strategy that allows for successful and sustainable weight loss. It's not true for everybody. It doesn't work for everybody that way. But for those people it does, that is a reason to perhaps consider it as one possibility for a way of eating. At Gail says, I would like to hear you address a WFPB whole food plant-based diet. It seems the Mastering Diabetes group has successfully adapted this approach for their type 1 diabetes. I've heard other people sing the praises of this pattern and so forth. Yes, a whole food plant-based approach is another strategy that many people use with some success to achieve fat loss, to achieve better insulin sensitivity. This is a complicated discussion about the roots of insulin resistance, which is, in my opinion, related to excess energy, which can be excess fat, can also be excess carbohydrate. All of those things come to play in different cells in different ways. We know that fat seems to increase insulin resistance in the myocytes or the muscle cells specifically and early on. So yes, a very low fat, very high carbohydrate, the right carbohydrates approach can be super successful. I have many patients who are on this way of eating, in addition to my other patients who prefer a very low carbohydrate, higher fat, higher protein approach. I have seen both work very, very well. Both can reduce insulin resistance. Both can allow patients to lose excess fat, especially visceral adiposity. Both will improve their numbers in regard to fasting insulin, fasting blood sugars, triglycerides, and HDL, likely also blood pressure. The impact on LDL-C, of course, is going to be somewhat different between those two approaches, and we can talk about that. And the impact on inflammation is variable. I don't see everybody on a whole food plant-based approach reduce inflammation. I don't see everybody on a keto or a carnivore approach reduce and lower their inflammation. That one varies. And the rest of that comment talks about the controversy swirling around Dr. Abs. Perhaps a stronger disclaimer that my reaction videos are not an endorsement of their creator would be appropriate. Yes, I think we've covered that. Thank you. All right, Jake Rusty. If carnivore seems to improve all important biological markers for ideal health, why would you not recommend that to all patients? Because I don't think it improves all markers related to metabolic health. Again, this impact on LDL cholesterol, ApoB particles is, for some people, more profound than others. And we can argue about the impact of dietary cholesterol versus the impact of fasting insulin and hyperglycemia and inflammation. That's an interesting conversation. And also, it's not the best approach for everybody. And there are people who just don't like to eat meat. So for those people, I'm not going to force feed them ribeyes. Like, that's not going to work for them. They don't want to do that. So I think having multiple strategies to offer patients, all of which can improve, and then we accept the trade-offs, right? What are the trade-offs for a whole food plant-based approach? Sometimes those patients have difficulty getting fat-soluble vitamins. They can have difficulty with nutrient absorption, iron deficiency, and the keto carnivore folks can have gut issues. They can have issues with elevated ApoB. And so every way of eating comes with trade-offs, every single one. And everything in moderation. The trade-off for that is that if you have food addiction or if you struggle with portion control or hunger, then you may kind of have that slippery slope. So even the most moderate of people probably has some kind of trade-off in that approach. You have to figure out what works for you, and we have to figure that out together. If you're in a clinical relationship with somebody who's helping you through this, and we may not get it right the first time. We may have to experiment. We may have to tweak. We may have to decide how we're going to address some of the trade-offs that happen as we adjust how we eat and how our life goes. So I'm shocked at how many doctors are still resistant to recommending, even with so much evidence. The evidence thing is curious. There's not actually a randomized trial or even a, multiple published case series of carnivore. There have been a few, I think, that made it into the literature as case studies, but it's not something that's been widely published. So from a medical and scientific standpoint, there isn't a huge amount of evidence for it. We have many of these case series where people improve their metabolic markers. Many of them will have a worsening in their lipid markers. Again, we can argue about whether, and reasonable people can disagree about whether that is a long-term problem or whether this is even a long-term intervention. Perhaps it's a short-term intervention to reset metabolism and to allow people to reintroduce more other foods over time. This is, again, why we don't have one size fits all, why there is not like, this is the perfect diet for everybody forever, in my opinion, as a plan. So Do I think it works for some people? Sure. And have I recommended it? Yes. Do I recommend it for everybody? I do not. And I wouldn't, for all the reasons we just talked about. At Marson, I was surprised to hear that a diet consisting of 70% animal products can be called carnivore. It may not even be ketogenic. I agree with that statement. So this I brought up in the video, and it is not necessarily how I would define a carnivore diet. And it's a little hard to make broad sweeping interpretations of what's going on when we don't really know what these clients or patients were eating. And the rest of the comment discusses, how easy it would have been to sort of turn this into a little bit more of a scientific exploration of these data. And I agree, right? So this is not a study. I never said it was. And I pointed out some of the things that could have been done to make it more useful to us, but it wasn't. And so I think, again, just like this, some people talk about their N of 1 and here's what happened to my labs and they got better. This is N of 50 and it's just a bigger series. But again, it shows us directionally what is possible in best case scenario with highly motivated patients. And we have at Terry Ward. I always hate when the CAC test comes up and talk about a score of 0 that you can have plaque in your other arteries. Terry has a score of 0, but has plaque in the carotids and in the aorta. And the CAC test does not test for soft plaque, only calcified plaque. When I first got my CAC score, I was excited because I had a score of 0. I thought I was out of the woods until I educated myself and found out there was a much more to it. So just be aware, do your homework and educate yourself. And Flower Pixel replies this: I see a lot recent carnivore dieters brag about 0 CAC. Non-calcified plaque is more dangerous. Okay, we love imaging here on this channel. So let's talk about this and dive deep into this question, because I agree, CAC, coronary calcium scoring, this is a non-contrasted CT scan, is not my favorite test. However, it is the one that seems to be the most accessible for people, meaning it's easiest to get and it's the cheapest of the options, and it's a decent screening test. Now, no screening test is perfect, meaning it won't capture absolutely everybody. And there are people on this channel who have had a CAC of 0 and had an event. So it is absolutely true that a CAC of 0 is not a guarantee. But when we look at large populations, we see that a CAC of 0 generally reflects a low risk of events in the next 5 to 10 years at a broad population level, much more so than in a CAC of, say, 10 to 100. That said, it is not a guarantee, and it does not image the soft plaque. And the younger you are, the less helpful that CAC of 0 is, because plaque, it's not like the calcified plaque is a different piece of material than the soft plaque. It is that it's a progression over time. Plaque starts non-calcified. It all starts as this very soft, vulnerable, lipid-rich material that over time, as it ages, just like wine ages, right? As plaque ages, it hopefully stabilizes, calcifies, and becomes inert or non-reactive, unlikely to cause a rupture event leading to a heart attack and stroke. And so if we're younger, most of the plaque that we have, if any, is going to be that younger, earlier lipid-rich plaque, and we are not likely to see that on a coronary calcium score. Conversely, if you are young and have a positive calcium score, that means much more to me than if you're older and have that same score, because I know that there's such a big plaque burden that there's already been some calcification and some progression of plaque that started much younger and earlier in life, all the way to that calcified stage already. And then what would that look like if things continued on that trajectory unchanged for the next 10 or 20 years? So CAC is not perfect, but it's accessible. And for many people, it is a helpful place to start. I would love if more people could get ultrasound-based imaging like a CIMT, even a regular carotid duplex, as long as you have the pictures and can show them to somebody who knows what they're looking at, even if the report reads as normal, because on a regular carotid ultrasound, like if you just go to your doctor and say, hey, I want you to look at the arteries in my neck, that's what you're going to get. You're going to get a regular carotid duplex. Most of that is just looking at the speed of blood flow through the artery, and they're evaluating whether there's more than 50% narrowing, right? If it's less than 50%, maybe they comment on the presence of plaque or not, but overall it's going to read as normal, because in mainstream medicine, nobody's planning any interventions for somebody with less than 50% narrowing. So But if you have those images and you show them to a doctor who's facile at looking at them, able to see that plaque and understand what it is, then at least you have the answer. The other option is the CT angiogram, right? CT coronary angiogram, or CCTA. That is the injection of dye into the arteries and the evaluation of the coronary circulation around the heart, and looking at both the soft plaque and whatever calcified plaque may be there. That is up and coming as sort of the new gold standard, but it's quite expensive. The radiation dose for that is higher than it is for a calcium score, and the contrast dye is a potential risk. It's low risk, but it's not zero. And if you want the computer-based or AI-based image analysis over top, like the plaque analysis, which is provided by companies like HeartFlow, then you are going to pay extra on top of that. And those techniques are very interesting. I would say they're very early, and it's a little bit difficult for me to recommend that as a long-term strategy because the technology is so nascent, and we're recognizing that there may be some concerns with how those algorithms are evolving over time. What is the minimal amount of change that can be detected in a particular scan from one to the next? So there's a lot of uncertainty in my mind still about how to most appropriately use that technology going forward longitudinally, meaning over time, multiple scans, using it as a surveillance tool. Ultrasound, I think, is a good tool. It's not widely accepted, and getting a high quality test like a CIMT, carotid intimal medial thickness testing by CardioRisk, like that's a bigger leap trying to get that. We just don't have enough people who are trained in that protocol around the world to offer that to everybody. So CAC remains an important tool for people to get a baseline. And even though it's not my favorite, I don't discriminate against it if it's the only imaging somebody can get. It's better than no imaging, in my opinion. Now, again, nobody should feel perfectly secure with a CAC of 0. I know physicians who will recommend nothing needs to be done if the CAC is 0 and lipids are elevated or other markers are out of whack. I'm not sure that I completely agree. There's more context that's needed, right? What's the family history? How old are you? If your CAC is 0 and you're 40, I'm not that impressed. If your CAC is 0 and you're 70, that's much more helpful to me. It still doesn't mean there's no plaque there, but it means that you've gone 70 years without calcifying anything. The total plaque burden is likely to be much lower. So for all those reasons, CAC is still something that I am recommending to patients from time to time, depending on where they are and what is available to them and accessible to them. But I agree, it's nuanced and it does not capture soft plaque. And in a perfect world, we would be able to get screening imaging covered for people based on insurance. And that's not going to happen anytime soon. And we would have more advanced technologies available to detect soft plaque for people going forward. And, I heard some interesting things over the weekend, like maybe we're going to be able to do plaque analysis with non-contrasted CTs coming soon. I don't know. The world is a mysterious and miraculous place, and I think that there's a lot coming up for us to be able to get better and better information. But for now, we image what we can because I think it still provides way more information above and beyond a standard lab panel. So let me know in the comments below what imaging you've had done, what you've tried to get, and what questions you have about this. Until next time, take really good care.